Hello, I'm Grace McCutchan, and today I'm going to talk to you about a systematic review that we've done to look at the psychosocial influences on medical help-seeking behaviour for cancer symptoms and treatments in lower and lower middle income countries. So throughout this presentation, I'll refer to these countries as LMIC. So I conducted this review as part of my role with the Wales Cancer Research Centre, and that's funded by Health and Care Research Wales. Global rates of cancer incidence and mortality are rising. In 2018, it was estimated that there were 18 million new cases of cancer and 9.6 million cancer deaths globally. We also know that cancer disproportionately affects lower income countries, with roughly 70% of cancer deaths occurring in LMIC. The importance of early cancer diagnosis to improve outcomes is well known, and that's to enable patients to access a wider range of treatments with curative intent. Later stage disease at diagnosis in LMIC may have a profound impact because the treatment at a later stage requires more advanced technology, which is generally less available in LMIC. So interventions are required in LMIC to facilitate the diagnosis of cancer in the earlier, more treatable stages and encourage patients to undergo prompt treatment after diagnosis. However, a comprehensive review evidence is needed to understand the psychosocial patient-related influences on medical help-seeking behaviour for cancer symptoms and treatment, in order to then go on and develop interventions to improve outcomes. To date, most reviews have focused on barriers to help seeking in high-income countries, and they report poor cancer awareness and negative beliefs about cancer as barriers to help seeking. So now we need review evidence in LMIC. We use systematic review methods to search for all available studies that reported patient-related influence on medical help seeking behaviour in LMICs. We searched multiple literature databases of Cochrane Library, Medline, Global Health and PsycInfo for relevant studies, and we also searched the reference lists for included studies for additional studies. We included all study designs and tumour sites in our mixed methods review to identify the predictors of help seeking in the quantitative studies, but also to gain an in-depth understanding of the barriers to help seeking in the qualitative studies. There was high heterogeneity in the included quantitative studies. So, for example, how time to help seeking was measured and defined. Therefore, a formal meta-analysis was not possible. So we used meta-analytic techniques to quantitatively summarise the use of traditional, complementary and alternative medicine, and all other quantitative variables were synthesised narratively. Qualitative data were analysed using meta-ethnography methods. Our search returned 3,976 studies, and after exclusion, 64 studies were included in the review, of which 24 studies collected data using qualitative interviews and focus groups, 2 studies collected data using mixed methods, and 38 studies collected data using quantitative surveys. The vast majority of studies included in the review focused on breast cancer, and most studies focused on observed help seeking. And this is where cancer patients or people with symptoms of cancer were asked to retrospectively think back to the time when they noticed their symptoms or were considering cancer treatment. 16 of the studies explored hypothetical help seeking, where population or community samples with no previous diagnosis of cancer were asked what they would do if they had a symptom of cancer. And 2 studies assessed both observed and hypothetical help seeking. This map shows where the included studies were conducted. So as you can see, most of the studies were conducted in African countries, and also most of the studies were conducted in lower middle income countries. So that's the countries that are highlighted in red. We found various barriers to help seeking in the quantitative studies. So 20% of participants used traditional, complementary and alternative medicine, and I refer to this as traditional medicine throughout. In those who used traditional medicine, they were 3.6 times more likely to experience longer patient intervals than those who didn't use traditional medicine. So by longer patient interval, I mean the time between noticing a symptom to first seeking medical help. Lower cancer symptom knowledge, misattribution of symptoms, cancer fear, financial barriers and competing priorities were also barriers to help seeking in the patient interval. Fear of treatment and the cost of transport or treatment were barriers to help seeking in the treatment interval. So the treatment interval is the time between diagnosis of cancer and the start of cancer treatment. There were 5 key themes in the qualitative studies. Typically, knowledge of cancer as a disease, the symptoms and the causes was poor, and for most, knowledge was obtained through social networks which perpetuated misconceptions and negative beliefs about cancer. Knowledge of lump symptoms was good, but painless symptoms were often misattributed and considered less serious, and this lengthened the patient interval. Cancer was also perceived as a bad and dirty disease, and there were many misconceptions about the causes of cancer. So often participants described cancer as being a result of a spiritual attack or a result of witchcraft. So consequently, their beliefs about causation did align to their behavioural response. So for many, that meant that traditional healers were the first port of call to remove the bad spell or witchcraft. Culturally, traditional healers are also used for a magnitude of ailments, so people would often consult with a traditional healer first for any health problem. Traditional healers were also easier to access, they were considered more affordable, and were perceived to provide a more holistic care when compared to modern medicine. Because of the misconceptions associated with cancer causation, cancer was often a source of shame and stigma. So cancer was highly feared, and patients often presumed that anyone with cancer would just eventually die. There was also a culture of secrecy in communities around cancer, mainly because people feared social rejection, and possibly also because people in the community were unsure if cancer could be contagious. So some women described being rejected from their family or even divorced from their husbands after a diagnosis of cancer. Social networks played a pivotal role in the decision to seek medical help with symptoms or treatment. So symptomatic people often asked friends and family for advice on ambiguous symptoms, which could either facilitate help seeking or prolong help seeking. It was common for women to require permission from their husbands or family to seek medical help, and if refused, this could lead to a long patient or treatment interval. Also, the family often financed medical bills and often prompted the patient to seek help from a traditional healer before going to see medical help. Modern medicine was considered expensive, ineffective and disfiguring, so patients often consulted with traditional healers to resolve their symptoms in the first instance. There was also a lot of suspicion and mistrust in modern medicine practitioners, and this really made people reluctant to seek medical help from them. A lot of patients also reported a power imbalance between themselves and the healthcare professionals. This Venn diagram shows the barriers to medical help seeking in high income and lower income countries, so we can understand which barriers may be overlapping between the two contexts. However, it is important to note that most of the studies included in this lower income review were conducted with women with breast cancer. So because many of the studies in high income countries were conducted with mostly men and women, it's difficult to directly compare, but it is useful to look at which barriers might be overlapping. So the barriers on the left are specific to high income countries. The barriers in the middle are commonly reported in both high and low income countries. And in the middle, the barriers that are marked with an asterisk are those that are more common in deprived communities in high income countries. Finally, the barriers on the right are more commonly reported in lower income countries. So you can see that many of the barriers to help seeking are the same across the two different contexts. So for example, cancer symptom knowledge, negative beliefs about cancer, other priorities, social influences are all universal barriers to help seeking, but there were some differences between the two contexts. So for example, in high income settings, men are less likely than women to seek medical help, whereas in low income settings, women are less likely to seek medical help because they rely on permission from male family members. In low-income settings, the use of traditional healers is also a unique barrier to help seeking. So we found that use of traditional healers was a key barrier to help seeking and was strongly influenced by causal beliefs. Therefore, visiting a traditional healer was the logical choice if you attribute your symptoms to a spiritual or benign cause. Use of traditional healers was also strongly influenced by cultural norms, where it's common to first visit a traditional healer with a health problem. In some contexts, women needed permission to seek medical help or relied on finances from family and friends. Due to cultural norms around help seeking from traditional healers and the perceived affordability and easier access, patients were often encouraged to seek help from traditional healers in the first instance prior to medical help seeking. Many of the barriers to help seeking are similar in high-income countries and low-income countries, such as financial issues and problems with accessing cancer services. However, there were differences related to gender and the use of traditional healers. So this is really important when we're developing interventions. So in low or middle-income countries, interventions must be adapted to reflect cultural influences on help-seeking behaviour by working with local communities and key stakeholders, and that would include working with traditional complementary and alternative medicine healers. Thank you.